Hello, everyone. My name is Siddharth Tambar, and this is the Regenerative Medicine Report. I am really excited about with who I have today with me. Today, we're talking about lower back pain and regenerative medicine. My guest today is the founder and physician at Cutting Edge Integrative Pain Centers in Elkhart, Indiana. He is double board certified in anesthesia and interventional pain management. He's also a member of the Regenix Network. And soon to be, he will be seeing patients here in Chicago at Chicago Arthritis as well. Welcome, Dr. Orlando Landrum.
Thank you so much. Pleasure to be here.
Thank you. I appreciate your time. I know you're very busy. What I'm really excited about talking with you today, Orlando, is you have a real expertise in lower back issues. So today we are talking about regenerative medicine and lower back pain. To give a scope or perspective on what a problem lower back pain is, this affects roughly lifetime 80% of the population in Western countries, and it also makes up the majority of workers' compensation and disability cases as well in this country. Knowing the scope of how big this problem is, Orlando, what would you say are some of the real gaps in care and challenges with treating lower back issues and lower back patients that we currently have?
Yeah, so I think to that context, it's probably one of the largest problems that's facing medicine today. And traditionally, really, when we look at back pain care as a whole, there have been a few treatment options that have been available. They've looked at potentially physical therapy, some holistic approaches and modalities that are in place. And then traditionally, the treatment option that has been, quote unquote, the supposed gold standard is that of spine surgery. And what we've seen is that those different options really haven't been able to solve the problem, particularly not effectively. And for a vast majority of people, it's actually created more of a problem than what we originally surmised. And so what we're looking for now is how can we be able to intervene effectively and certainly not do any harm, but hopefully do some good.
That makes a lot of sense. I think a really classic thing that we hear about lower back pain issues is that somebody can go through various interventions, whether it's non-surgical, steroid injections, or actual surgery, and they're still left with as much, if not more pain, and then things progress over time. What really drove your initial interest in regenerative medicine? And in particular, when it comes to back pain issues, what really sort of got you kind of interested and excited to get involved in this sort of work?
Sure. Phenomenal question. Thank you. So for me, originally, I come from that traditional circle of how can one intervene, right? And in Boston, where I trained, we did those type of things like epidural steroid injections. We did radio frequency ablations to target those areas of the aspect of the spine. We did spinal cord stimulators. We did intradiscal procedures like IDED and nucleoplasty and other things of that nature, and endoscopic discectomies and other things of that ilk. And what we found is exactly what you stated before, is that there were so many patients, a good number of patients, that didn't get sustainable benefit, and most importantly, return to the ability to be able to do the things that they loved and they really cared about the most. And to me, although I was trying to push and make those things work, and we're trying to find ways to be able to fit multiple different aspects of therapy that we would provide to fit together kind of like puzzle pieces, there was still something kind of missing. Like you had a puzzle when you were a kid and you just couldn't find that one piece that made the whole thing kind of come together. And honestly, what ended up happening is I had a patient mention to me the aspect of them pursuing regenerative medicine and came back to me and they said, "Hey, you seem to be a pretty smart guy and you're pretty innovative. Why aren't you doing this?" And I was like, I don't know. This is something I need to look into, and they're like, yeah, you should definitely pursue this and get some further understanding and insight. And so I think, as we know, we don't know all things. And I think having some degree of humility and being able to go out and say, let me kind of learn something better. Let me learn something that's different so that I can serve my patients and the people that come to me, in a much better fashion is really what was the pursued course. And I saw just a whole different perspective of how you can get benefit without the same side effects that we had that were deleterious to his patient, both in the short term and the long term. And really were able to provide a service that more people should be doing for patients, and that patients can receive, but aren't as well aware of it as what they should be.
That makes a lot of sense. I think one of the really interesting things about regenerative medicine is that as a professional, as you get involved in it, you start to realize how many layers and depth there is to treating a lot of musculoskeletal issues. And that some things that seem really, really straightforward and basic, that we've traditionally seen as here's your one structure that's a problem, you start to realize how much more interconnected the body is, whether it's a person has a knee problem and their back is driving some of it, or you realize that even looking at something like a back or a knee, that there's sort of so many layers involved in that that are frequently ignored. It's really quite extraordinary. And I think one of the exciting things about regenerative medicine is, as a professional, how much it really forces you to learn and adapt and sort of relearn what you think you've already learned and are an expert in.
Can I comment on that last statement a bit? Because I think that you're 100% right on the money. And it's been actually really very validating as a doc and as a physician when you talk to patients and you say, you know what, it's okay for when you talk to me about your back to talk to me about your hip and your knee. And they are so much just jubilant in some ways, even though that they have the pain, to hear that someone's not trying to cut them off and segment their body into saying, you know what, no, there's a doctor for your knee. No, there's a doctor for your hip. No, there's a doctor for your back. Well, yeah, I think it might be a knee problem, but I don't do that. And to talk to patients and see that interconnect, they're like, yeah, this is what happens when I walk like this and I have this problem on this side, but I think it correlates, but I know that might be silly. And the reason why they say that might be silly is because they feel like they've been forced to that because of the various different pressures that make docs in traditional realms have to segment because of time and expense and such. But to be able to look at it from a regenerative medicine standpoint is, as opposed to us trying to treat body parts, how do we treat the person?
Yeah, that's wonderful. I mean, it's amazing how much the more you learn, the more you realize things like the hip bone is connected to the knee bone and to the backbone, that there's more value to that than we realize. There's this really great book called Anatomy Trains, where they talk about how the fascial layers from the head to the toe are so interrelated and connected. It really makes you think about anatomy, physiology, pain, dysfunction, normal function in a very different way. It's actually very cool. Before we start getting into some of the nitty gritty about regenerative medicine treatments, I think a really key part of regenerative medicine is really maximizing everything a person can do on their own. When it comes to the back itself, what sort of things do you recommend patients do before they even jump to an intervention? What are the kind of things that an individual who has back pain can self-care and self-manage on their own before they jump into some of these other kind of treatments?
Sure. So I think that there's a couple different things that really are mainstays that really make a lot of sense. And sometimes traditional medicine doesn't really focus on it all that much. And that's the aspect of both exercise as well as diet, and as well as different social habits that exist. And when we look at medicine as a whole, there are a number of things that we really kind of delve into towards doing these sort of exotic, elaborate things to try to find a solution. When we actually take a look, there may be some other elements that provide for good value. So kind of commenting on that, when we take a look at diet, is there a way to be able to look towards optimizing the diet towards an anti-inflammatory type base? And what does that really mean? And are there supplements that really actually have scientific value that you can be able to utilize in appropriateness and provide that element that allows for you to have decreased pain because you're able to use traditional foodstuffs that are able to provide good value? Second is the aspect of exercise. What's reasonable? What's appropriate? How can you be able to do strengthening? How can you be able to do stretching and make it not just the aspect of an episodic component of care like you might have in therapy, but how do you make it a lifestyle change, right? So for whatever it is, whether it's from walking to doing chair yoga to doing other items that are going to be part of your actual true change in your lifestyle that you can be able to take over, and it really influences not only your daily routine, but also what your eventual impact happens to be. And then how do you deal with some things that are the tough things, right? What are the real challenges that we say, okay, are we really looking at our smoking? And how does that affect the aspect of vasculature in the intradiscal component? How does that really apply to the aspect of your back? How are we looking at how that affects other structures that are ligamentous in nature that can potentially impact what's going on with our back pain? And those tough choices, as patients and as people, we have control over. And we have to kind of have some degree of accountability to be able to figure out how can we be able to improve that.
Yeah, that makes a lot of sense. Without a doubt, the regenerative medicine approach, it's holistic in the sense that you need to understand concepts of stability and instability. You need to understand symmetry, how that affects things, inflammation, neurologic health. It is taking into account all those sort of things. So moving on to actual regenerative medicine treatments for the lower back, what orthobiologic options do you think individuals should be considering when it comes to their lower back? What should they be thinking about first and foremost? What is the full range of things? There's a ton of things that are out there, but we know there's data for some things rather than other things. What are you as an expert looking at first and foremost?
Yeah, so the way I think about it, like many things in medicine, is I think we make small inroads for us to try to see if we can get big gains, right? So I don't think that we start off with a really aggressive treatment option, because the thing about this is it's not where you're using an external source in order to get improvement. You're using your own autologous cells in order to get some degree of improvement and healing. And you don't quite yet know how robust your healing response might be. So to me, I think that there's a number of things that, particularly as Regenix providers, we're able to provide. Things like platelet lysate, things like traditional SCP or PRP type components, or us looking at the aspect of bone marrow aspirate. But really, I think it's a combination of some of the things that you mentioned before in terms of things like symmetry and stability. And can we take that and focus on what are our key pillars that by impacting that with just a small treatment, we get a much more bountiful return. And I think many patients sometimes are kind of confused because there's a lot of different offerings that are out there. And there's this shock and awe of that we have to go for the best, the bright beneath that many people can get a heck of a whole lot of return by having the precision of knowing not only type, what element, what concentration to utilize to get the best response.
Yeah, that's wonderfully put. You broke out, or you broke up a little bit along the way there, but I think that's so smart, right? You always should try to use the least invasive, the least risky option up front, and then sort of escalate as required. Naturally, as there's better understanding for treatments, you get a better sense for when is it appropriate to escalate right off the bat versus when is it okay to start with something that's a little bit lower level. You made a really great point that how much gains you get sometimes from smaller, very focused approach to things. I think people are sometimes surprised at how much better they can get just from improving stability even a little bit. That even when you look at imaging that can look pretty advanced or significant, just how much benefit a person can get from a joint or segment or back that's even just a little bit more stable, what that means in terms of actual not only pain relief, but functional improvement as well. So you talked a little bit about the different types of platelets that you're employing, some bone marrow aspirate concentrate as well. Tell me a little bit more about how you're using platelets. You used a couple terms that maybe not everyone's going to be familiar with. Platelet-rich plasma, most people understand because that's been out for a while now in terms of using a high concentration of your own platelets for joints and tendons and things like that. You also talked about platelet lysate. Describe what is platelet lysate, how are you using platelet lysate, why is that useful in lower back treatments as well?
Sure. I think I got the vast majority of the question. I believe our network might be breaking up a little bit on our side as well. But I think it's more of what's the detail, when do you use what and where? And so it's interesting. I had a call from a patient most recently that presented with back pain, right? Obviously, as we're kind of discussing this. And as we got into the depths and details of discussion, they're really kind of astounded about the amount of work and precision and thought process that's out there, right? So when we talk about the utilization of different types of orthobiologics and how we would use that, it's been worked out to say, okay, or at least we have a pretty good understanding of when you're looking at a joint in the back, for instance, the facet joint that allows you to be able to bend and twist, it is going to be benefited by a certain concentration of a certain biologic of a platelet type dynamic, right? Traditionally, something that's going to be a little bit more of a slow release. We look at the nerve that exits out from the foramen that gives our various different motor nerve supply, right? To use that same type of biologic in that area is a little bit not ideal. It has a couple different side effects that can give you some problems and some issues. So instead what we do is use something like a platelet lysate, meaning we take that same type of element that you have in the joint and we provide more of an immediate release, which is more gentle, that is able to provide benefit to that nerve root and give a much better environment that really produces a more holistic and more beneficial and more efficacious healing process. So where you use that product, even though it may have some similarities in how it's used and how it's formulated, can have major differences in that overall result that you get.
Yeah, that's wonderful, right? Taking into account what's the actual issue that you're treating, what's the actual, who's the patient, what are some of their other medical issues as well. Really smart and the right way to do this kind of thing. I think the other kind of big thing that you made, that you referenced was also image guidance. That really is the gold standard now for these kind of treatments. And so, especially when you're talking about lower back issues, being precise down to a sub-millimeter level is a difference between a good result and a not good result. So I think those are all really good points. So I'm going to give you a couple classic patient presentations that I think lower back patients frequently present with, and give me a sense for how you would address some of these with orthobiologics and a regenerative medicine approach. In all these cases, assume that these are people that have done all the ideal self-care things. They've been really diligent when it comes to physical therapy, activity modification, cutting out all the bad medications that they shouldn't be taking, ideal with their diet, emphasizing anti-inflammatory food and lifestyle, and they are your ideal candidate that's ready to step up to the next thing. So probably the most common sort of lower back issue, let's say this is a 65-year-old person who's had chronic pain for 20 plus years, that's progressively getting worse, having some difficulty with activities, bending over, reaching up for things. On their imaging, it turns out that they have chronic multi-level degenerative changes. There's emphasis on the MRI report about facet joints and disc problems and maybe a pinched nerve in the foramen and stuff like that. How would you, as an expert, approach that with an orthobiologic regimen?
Good question. I think that this is so common, right? And there are so many patients that have this problem and issue, and they have resigned themselves to saying there's nothing that they can do. And for me, I feel like that's disheartening, because there are things that we can do and there are evaluative processes that should be done. And I think the initial portion of this will sound cliche, but I think it really needs to be delved into aggressively and understood, because it is the foundation. So the first two things that I think make all the sense for something like this is a strong history and physical. And I think if you hear patients get that response from their providers, like, oh yeah, you're supposed to do that. Yeah, big deal. No, tell me what you're going to do. But it makes a huge impact. And the best way I can say this is, as a patient, have you had a doctor really just sit down and just listen to what it is that you stated? Oh, they might have heard you said that you had back pain and it was a 9 out of 10 and it was present in the back and it was on the right side and it went to the right leg. But they hear when, why, and how. Was it worse when you walked through the grocery store and it started after 10 minutes, or that you couldn't be able to go to like dance class? It caused you a problem or issue. Or it was worse when you bent forward and you couldn't really be able to pick up things off the ground. Or it's worse when you got out of your favorite recliner and you twisted and turned. And so those type of things matter, because when we talk about the aspect of degenerative problems that exist, the thing that has been one of the major downfalls in traditional medicine is that we want to say there's one thing. And the radiographic aspect of the imaging, we're like, okay, what's the worst thing that we can find? Well, maybe it's not just that it's one thing, but it's a mixture thereof. And what we need to figure out is not only what is the priority of the mixture, but how does it impact you functionally? How does it impact your lifestyle and your quality of life? So if you tell me, you know what, hey, I have grandkids that I want to be able to play with, and I want to be able to get down on the floor, and I want to be able to bend and twist, then we need to give that context to say, okay, the facet joints that let you be able to bend and twist, that influence your ability to be able to get off the ground, that influence your ability to be able to turn and twist, to be able to influence your ability to be able to pick up the kid and be able to move. Those are things that we really need to kind of look into. Or if you say, hey, you know what, I've finally been able to finish, I've retired, I've done everything that I wanted to, and now one of the best benefits I get is that, hey, you know, we know Chicago has 2 seasons. It's construction and it's the aspect of summer, right? It's construction and winter, right? Those are the 2 major seasons that we got, right? So you got a time to be able to kind of walk outside, exist, and really be able to spend some time with your spouse and in the summer sun while we got it, right? And you want to be able to walk, but you can't walk that far, right? You've got your knees shored up, you got back pain, and the back pain just is incessant, and you're trying to push through it. You're doing topicals, you've done all the various different types of interventions and such, and you still can't get benefit. Then we need to look at, is this possibly spinal stenosis? And the question is when you look at that spinal stenosis, i.e. a squeeze is present in the back, is it present just from a structural cause, or is it dynamic? And if it's dynamic, meaning so it happens when you have mobility and it's motion, how can we be able to improve that stability? How can we be able to make that better? And the fact of the matter is those things may not exist separately. It may exist that you have multiple different ones of those, and we need to figure out how to put those things together.
Yeah, no, that's great. I mean, that is, you know, the original regenerative medicine treatment is prolotherapy, and the emphasis there is on biotensegrity. Taking a structure, and that can be any kind of structure, a biologic structure, it could be something like the lumbar spine, and taking components that are connected and loosely connected, but in tension and compression, they function at a very high level. They create structure and they enable a very healthy process to enable a very high level of activity. And if multiple ones of those are off, you need to look at all of them. So that's really smart. Okay, so in that vein then, so if that patient comes to you and you've done all that and you've talked to them about their favorite recliner and their kids and all that, so bottom line, what is your approach in that case? You talked about facet joints. Tell me about some of the ligaments, the nerves, some of the other things. Are you hitting all of these things? Are you only hitting 1 or 2 of them? What's the approach you're taking from that regenerative medicine approach?
Yeah, so I think to kind of reiterate that point, we're not going to take and segment this patient. We're not going to chop them up and say, hey, we got one area and this other area has no interconnectivity. We know that those different structures, they function together as a team, right? And so to really make that work, we need to hit all those different points and say, how can we be able to make this better and more, have it be the aspect of greater than just the sum of the individual parts? How can we really be able to put this piece together to give a really good response? So we would target multiple different areas, and we'd prioritize those areas that is related to the quality of life, but we wouldn't just take one piece and say, that's it, and we're done, and then we'll come back at a later time. No, we want to address the person as a whole.
Yeah, that's wonderful. So you had alluded to platelet lysate before. what would be the right indication where you would use platelet lysate in place of, let's say, a steroid epidural? What's the right sort of patient presentation that you might use that in place of that? And yeah, tell me that.
So just being quite honest, I grew up using epidural steroids. And occasionally still do from time to time if the patient is just adamant about pursuing that course. But from what we've seen in the literature, number one, platelet lysate is way more efficacious than the aspect of steroids. We know that. Number two, there's some deleterious effects of using steroids. And so if given the chance and choice, we're going to look to be able to use platelet lysate because it's going to give benefit that's going to be better than a traditional epidural. And number two, it's not going to do as much harm as what you'd have, if any harm, as what you'd have with steroid. So traditionally what you're using it for is the aspect of a nerve type problem. You have that burning sensation, that tingling sensation, or to use fancy doctor words, paresthesias or dysesthesias that you'd kind of feel, that crawling sensation, a sensation of fire in the middle of the night that really kind of gets into that arm or the leg, which is most likely being caused by a nerve that has some disruption thereof. And so those are going to be the times we're going to use platelet lysate to be able to try to bring that nerve back to its normative state.
Fantastic. Okay, case number 3. Let's say, when you look at a lot of MRI reports, you see the word disc disease everywhere. It seems like radiologists are obsessed with this. You just see disc, 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 disc. And so patients, physicians, you start to think that it's all about the disc. You've talked a lot about how you need to look at the whole person, the whole functional unit, everything, treat it properly. But now let's say there is a case where really it's only the disc. So let's take a young person, 25 years old. They've got pain across the lower back that's really worse only with activity. They don't have a lot of shooting pain down the leg, sciatica symptoms. Their imaging really just shows a disc that seems to be irritated or has some classic findings that would indicate that may be the cause of their pain. They don't have a lot of other issues in terms of facet joints that are arthritic. They don't have a significant pinched nerve on their imaging either. How would you look at that patient? Is that a patient that you would look at actually treating the disc? Would you take a different approach firsthand? And if it comes to treating the disc, what would be the approach there?
Sure. So I think your question is obviously a very astute one. We more than likely wouldn't go after the disc immediately. And you have ruled out a number of the other etiologies or potential options that might give axial pain, meaning the pain is just localized to the back and not going down the aspect of the leg. So things like facet and other areas that are in place. But what we also want to do is make sure that there's no ligamentous issues, there's no muscular imbalance, and those type of things are going to be huge role to play, and particularly someone at that age that may have had some other traumatic event or may have had a muscle pull or something along those lines, where we want to take a look at the multifidus muscle that really has that structural support that's in place. We want to take a look at some of the aspects of the ligaments that connect the spinal elements that are in place and make sure we're not missing that. And I know that sounds like a very simple statement, but I come from an interventional pain background, and I come from some places that have really been some pioneering events, and at no point in time did we really talk about ligamentous structures as being a major pain generator source, and in regenerative medicine, it's been an eye-opening piece to say, oh, these are things that we really need to look at, give a strong degree of credency and have an understanding for. And to make a slight divergence, I think that there are many providers that are out there that don't really, who are doing and work in the regenerative space, that don't give it as much thought process as what they probably should.
I have a personal example of how ligaments can be surprisingly injured and sometimes be very important. I was scanning my own knee once under ultrasound in the office. I had a little bit of downtime, and everything looked fine. As I got up, I accidentally banged it against the ultrasound machine. So, I had pain at that point, obviously, over the inner part of my knee, over my knee. So what a great time to actually look at the knee now. So scanning under ultrasound at that point, there's a small, tiny little divot in that medial collateral ligament now. Pain is gone. I don't have any significant instability on exam or an ultrasound, but for the rest of my life, when I image that knee, you'll see a little ding in that ligament. You get enough of those, that's when ligaments start to really kind of play a pretty big part of what's driving pain. What's interesting is a lot of those kind of small little clinical, but you can see them on really kind of dedicated clinical exam or on ultrasound. Ligamentous injuries, they don't really show up on MRI.
Right.
Sometimes they do on ultrasound. I think ultrasound is better for some ligamentous issues, but they don't always show up on MRI. And so a lot of times when you talk to a regenerative medicine expert and they're sort of obsessed about treating ligaments, or at least they should be, the reason is because sometimes those tiny little dings, if they happen over time, they do create a subtle unstable segment. And so always going back to those ligaments is definitely key. The last case that I have for you, and this is essentially my mother, is a 65-year-old woman. She's a little bit older than that now, who presented with complaints of hip pain for roughly, let's say, 35 years. And it turns out ever since she gave birth to her older son, me, and then later on her younger son, my brother. And really has essentially had some lower back, buttock, hip pain going on for decades. Has had a pretty extensive workup, has had a couple of diagnostic injections, and finally determined to have SI related pain, whether it's SI joint, SI ligaments, whatever you want to call it. SI joint issues, right, frequently disregarded, but makes up at least 1/3 of lower back pain issues. How would you approach an SI ligament issue? Because I think SI joint issues, SI ligament dysfunction, whatever we're calling it, that this is such a key part of the lower back. And it's one that I think is kind of a low-level epidemic that no one really pays attention to. What's the right way to treat that?
So I think that is probably one of the most interesting questions that I've gotten. And the interesting dynamic of it is the following. So in some of the things that I've done prior to coming into regenerative medicine, we did some pretty high involved treatment options. So I was actually in a course that was for endoscopic spine surgeons, right? Where they were looking at how to do minimally invasive lumbar fusions, right? And it was a group of docs that were kind of talking about some of their successes, but most importantly, some of their failures, to figure out how can they be better, right? And in one of the aspects that really came up, which is, I think, shocking to a number of docs in the room, and certainly would be incredibly shocking to patients that would say, oh my, I never knew that, is that they recounted so many stories of people that got fusions for what was a lumbar problem, or at least so it was believed by both the surgeon, the patient, as well as the radiologist, and come to find out it was an SI joint issue. And what really was taken into account, or wasn't rather taken into account, was that evaluation of that SI area. It is incredibly complex. It has a number of different elements that are involved with it. And the interesting dynamic is, in traditional medicine, we think about SI joint problems in isolation. But when you look at it from a regenerative medicine standpoint, is really that aspect of the pelvic ring. And what's going on with the left-sided SI, how does that connect to the aspect of the right side, and how does that connect to the pubic symphysis? And those things act in continuity. So that's the first. The second is the ligamentous structures that really kind of support that SI area is really robust. It's the joint that actually provides so much structure for our body weight, right? And so normally when you take a look on an x-ray, it looks like a fairly simple joint that doesn't have much mobility. But when you take a look under anatomical texts that look at the amount of ligamentous support, it's robust. And there are a number of things that really kind of play a role. And quite honestly, admitting my own degree of learning that I needed, I was surprised. I was like, oh my gosh, I've injected SIs and thought it was no big deal. Oh yeah, no big deal. Put a needle in an SI, big deal. I've done radio frequencies of that area. I've done fusions of that SI area. And little did I know that there's a much better way to be able to kind of address that. But when we look at the greater picture of that, the other parts that play a role in there are the areas of the aspect of the S1, S2, and S3. What are our neuronal components? And not just the nerve part that's there, but how does it feed and innervate the muscles that supply that area in that region? So we really need to be looking at the gluteal muscles. And normally when we think about this, we think about it in the social context of it being all one muscle. But as we know, there's actually 3 muscles that are really prevalent there and can give referred pain in a whole host of different places. So we really need to kind of take a look and evaluate that in full in depth, as well as some of the other adductor muscles that come in from the front portion, and how does the hip play a role in this. So, excuse me, when we look at that SI area, it's one of the most complex areas that can benefit from that traditional holistic approach that we were talking about in the very beginning, of how can we look at regenerative medicine and not look at it in isolation, but look at it from a stability standpoint, i.e. let's look at what's going on with the components of the ligament. Let's look at that neuromuscular component by seeing how does the nerves function, or is there some potential imbalance that's coming from a higher level that's affecting this area and region, and how that connects to our innervation, as well as the stability component that says, how does it interconnect between the left SI joint to the right SI joint to the pubic symphysis, and really evaluate that in the whole and treat it accordingly.
Yeah, that's fantastic. That, I mean, you could literally do just like a whole conference just on SI issues. You could do a whole, like, probably textbook on it. And I think you really explained it really well. Well, before we conclude, and I really appreciate your time, Orlando, tell me, what are you most excited about when it comes to regenerative medicine? What you see coming up in the future? Like, what is it that you're really most looking forward to? That I think, you know, in a world where there's sometimes a lot of negativity and pessimism, I think when the general public sometimes hears from physicians who are really excited about what they're doing, I think sometimes they're a little bit surprised, and I think it's worthwhile for physicians to maybe elaborate on that. So what are the things you're most excited about regenerative medicine coming up in the next few years? And tell me some about that.
You know, I think it's an interesting phenomenon that many patients really haven't had this exposure to having an understanding about how impactful and life-changing regenerative medicine really can be. I think that there's a broad scope of different practitioners that are out there, but I think that there are certain groups that are really pushing forward the science behind how regenerative medicine functions, both on the molecular level as well as the structural and clinical applications. And I think those are the things that are really interesting. You know, when you hear about some groups that, you know, are believed to not be as credible, and then you see other groups that are saying these are the scientific underpinnings, and this is really how this functions and how it works, and how we look at not just the aspect and isolation of one orthobiologic, but how do we use this in combination? How are we able to use different elements together at different spots to get an improved efficacious response that we really didn't realize that that was going to take place? As we look at that aspect of what we talked about before, how do you optimize certain other extraneous factors, whether it's diet or other elements along those lines? How can you be able to improve your regenerative medicine responses? I think that there are certain things that are out there when we look at how can we target the areas on a different vantage point than what we have. So historically, we've been doing the same type of epidural treatments for decades, right? And I think that there are other ways to be able to enter into the space, do some things in a different, more novel type of way that can be discrete, that can be precise, using imaging and using other tools to be able to deliver those biologics in a way that not only is safe, but also is revolutionary. And I think when you see the type of responses that you get, patients that can come back and just do the stuff that they couldn't do, sometimes as a provider, it's surprising to me, where you're just like, oh my gosh, you got such a good response, and you're like cheering for them to go out and take their lives back and really find their place in the world that they'd kind of shrunk from. And I think, you know, one of the things that we don't talk about so frequently as physicians is that psychosocial, and that part that really affects people at a much deeper level. But it's one thing when you've had disability forever, but it's a whole nother thing when you've been functional and you've been able to do things and you remember it and you're like, I can't do and be that person I was before. And to be able to give that back to someone is invaluable. For them to be able to do the things that they couldn't do before, and now they can be able to get back to doing those things, as opposed to saying, I have to settle. You don't have to settle. There's a way to be able to be that person that you were before, or pretty darn close to the things that you were able to do, without having to say, you know what, I just have to kind of live a modicum of a lifestyle and I can't get to doing the things I really want to do. So those things I think are incredibly exciting.
Fantastic. That's a great way to end this, Orlando. I appreciate your time. Thank you very much.
Thank you for having me.
Fantastic. For anyone who's listening, Orlando's based out of Elkhart, Indiana, and will be coming to Chicago soon. Again, to be seeing patients at Chicago Arthritis and Regenerative Medicine. And thank you very much for your time. And if you'd like to learn more about regenerative medicine, some options to check out. This is cross-posted over on Orlando's Facebook page as well. You can check that out. You can check out my own site and, of course, regenix.com. And thank you very much for your time and have a good day, guys. Bye-bye.